This is LegalEthicalCultural. I'm going to be presenting legal and ethical considerations and cultural considerations in obstetrics. Malpractice, legal considerations for obstetrics. Malpractice issues in maternal newborn nursing continually increase. We as a nurse need to remain very cognizant of the scope of practice, our standards, and other issues that direct nursing care for this population of patients. Nurses have more responsibility today than in the past, which does open the door to greater legal risk. We are covered by our employer for malpractice. However, some nurses do choose to carry their own malpractice insurance. Some reasons for it. If you think about obstetrics, we all think, oh, we're going in, we're going to have a baby. It's going to be roses and cupcakes and sunshine, but it's not always that way. There could be an intrauterine insult. We don't know when it happens, but families, they have the same thoughts that we have, that it's all sunshine and roses. So when an accident does occur, in the intrauterine environment, they're going to seek someone to blame. They're going to want to blame someone for it. There's unrealistic parental expectations. Excuse me. Negligence, accident, poor judgment, incompetence, and miscommunication, and staffing shortages all lead to malpractice lawsuits. The Nursing Practice Act and the scope of practice, they are designed to protect the public and are used to judge the quality of care that's provided. Legal interpretation of actions within standards of care is based on what a reasonably prudent nurse with similar education and experience would do in similar circumstances. Failure to do so is going to result, of course, in lawsuits. We have other professional organizations, the ANA, A1, NAN. In addition to these more formalized standards, standard agencies often have their own policy and procedure books that outline standards to be followed in that setting. These references serve as the safest facility-based resource for nurses. Care that deviates from the guidelines does not actually per se establish negligence, but these publications can be powerful evidence of the standard of care. If you're uncertain how to perform a procedure, you need to look at your policies and procedure book. Follow the printed guidelines. Ensure that you're following that set standard. Practically, we should, A1 is one of those that, let me try that again. A1, the Association of Women's Health, Obstetrics, and Neonatal Nursing, sets many standards for obstetrical care of patients. One of those is a postpartum hemorrhage initiative at this point in time to prevent recurrent never events, is what they're calling them, for the postpartum hemorrhage. They don't want it to happen at all. So they've actively gone out and sought other hospitals that are willing to participate in programs that aid in the prevention of that. We'll talk more about postpartum hemorrhage along the way in some more lectures. Informed consent, that's just a given. Y'all have heard about informed consent. This is nothing new to you. It does protect a client's right to autonomy and self-determination. No action may be taken without that person's prior understanding and freely giving of that consent. And that pertains to any nursing, any medical, or any surgical intervention. Person is ultimately responsible for the treatment or procedure, should provide the information. And who is that typically? That's typically the physician. An oral consent is legal, but written consent is easier to defend in a court of law. The nurse should also document in the chart the patient gave informed consent. Parents have the authority to give consent for their minor children under the age of 18. There are special problems that can occur in maternal newborn nursing when a very young mother gives birth. In most states, a pregnant teenager is considered an emancipated minor, and so she can give consent for herself. But the state of Arkansas is a little different. The law requires that a parent or guardian must give permission for an abortion for any child 18 years or younger. Refusal of treatment, medication, or procedure after appropriate information requires that the client sign a form releasing the doctor and clinical facility from liability. What would that be an example of? What if we have Jehovah's Witness? I was just talking about postpartum hemorrhage. If we have a Jehovah's Witness who doesn't want blood transfusions, then we have to get that consent signed for refusal of the treatment. We have to have that releases us from any liability because they have chosen to do this because of religious reasons. Everyone has a right to privacy. No one's exempt from that. We all have that. We have the right of a person to keep our person and our property free from public scrutiny. In women's health, we see unnecessary exposure of a woman's body. We also need to utilize cultural considerations. Look at private adoptions. That's a big one right there. You probably will not take care of any infants in the postpartum area that are being that they're put in a or you might not take care of the infants that are being put up for adoption. You might, however, take care of the mom who has given birth. And our job at that point in time is to allow her to express her feelings, express her emotions, but we don't need to sway her one way or another, and we need to respect her privacy. Don't walk out to the nurse's station talking about it. The adoptive parents could be out there waiting to see the baby. So, and here's another thing I'd like to ask you. What do you think violates patient privacy and confidentiality in this day and time? It's a big one. It's one that we all utilize, and that would be technology. Be careful of those things that you post to Facebook and Instagram. If you say it's a wonderful day in the clinical setting, I just don't understand why some people decide that they need to put their baby up for adoption. It is so precious. You know, you're not referring to it as a male or a female. You're not referring to that patient individually, but if this person catches wind, if anybody knows that what you're talking about, there's comments made, even though you have not specified who that patient is, you have talked about that patient, and it can come back to bite you. Delegation, a big one, big one. I talked to in your not to I talk to you when you get to your leadership med-surg semester at the upper level. I teach most of the leadership component for that semester. Delegation, of course, was one of the big ones. We kind of sit back and think, it's no big deal. Everybody knows to do their job. Everybody knows to do this. I don't know why we have it's important that we have delegation in the curriculum, and it's important that you learn how to delegate appropriately. It doesn't matter what you do in a clinical setting. I know that you're all nurses, and I understand that things in the real world operate one way. But I want you to understand that there is a perfect NCLEX world. And in part of that NCLEX world, there's no gray areas. It's all black or white. That is it. There's no purple or pink. There's no what ifs, ands, or buts. So delegation is very important for you to hone this skill and learn how to delegate appropriately, even if it's just on test questions, even if it's just for HESI and NCLEX. Now, again, you can get yourself into some legal problems if you don't delegate appropriately. The criteria for delegation, it must be clearly defined and thoroughly described, have a predictable outcome, require little or no modification from one patient care situation to another, involve no ongoing assessment and no significant interpretation, and be within the training and competence of the assistive personnel. I just taught all of this in the last semester during that senior level. I had a student who texted me and said all of the The delegation and leadership was part of her NCLEX. It wanted to know that she could delegate and prioritize the correct way. If the RN is to supervise the unlicensed assisted personnel, they have to provide guidance, they have to provide direction, evaluation, and follow-up for getting that task completed. We have to maintain accountability for outcome of those tasks. If you, the registered nurse, determine that someone who is not licensed to practice nursing can safely provide a selected nursing activity or task for a patient, you delegate that activity to that individual, then it's still up to you, the RN, to remain responsible and legally accountable for that care that was provided. Documentation, another big thing. That is very, very crucial and important in our practice. Nurses involved in a malpractice case are judged by the degree to which they have met the standard of care that was defined by the Nurse Practice Act, and that's within their state, national, or state standards. And the standards defined by specialty organizations. So if you're practicing in women's health, A1, a specialty organization that defines certain standards that we are to follow. Excuse me. Because you cannot accurately predict bad outcomes, good documentation is absolutely mandatory. There's no ifs, ands, or buts on that as well. We have to have a very good record that fully documents all that occurred. And it makes the plaintiff attorney much less likely to pursue a lawsuit. And courts have noted typically that the assumption is that if a case is poorly documented, it creates a presumption of poor care. Let me just give you an example. I always like to use this one. I'm thinking about women who are post-op in women's health. We have a lot of women that have come through after they've had a hysterectomy. The physician orders sequential TEDs. So we have the sequential TEDs on our patient. However, that morning we go in to do our initial assessment and they're off. No big deal, right? That's what we sometimes would think. It's no big deal. The patient says, I don't want to wear these. I don't want to wear these. They make me itch. They keep me awake. They're irritating me. So she takes them off. You don't call the physician. You don't get an order for them to be discontinued. The only thing that you happen to chart is sequential TEDs not on at this time per patient request. Okay, it sounds like it might be okay. It sounds like that could be a good amount of documentation. Wrong, it's not. You did not provide information in there that stated that you provided teaching for that client. Why does she need to wear those sequential TEDs? If you didn't provide that for her, you didn't acknowledge that you provided that for her, the patient takes the sequential TEDs off. She's a non-compliant patient, doesn't want to get up and move around. She doesn't want to walk the hallways. She develops a DVT. She throws a clot. When she throws that clot, she dies. All you have documented is that the patient didn't want her sequential TEDs on, so they weren't on at that time per her request. You didn't have anything in there about teaching, so what do you think it's going to have? The court is going to assume that you did not provide the appropriate care for this patient because you didn't do your job and teach her appropriately as to why that she needed to wear those sequential TEDs. And because of that, she has died. So this is, I know that seems like a very drastic case that I developed there, but I'm just trying to show you why it's so important that we document. Video cameras in labor and delivery, not necessarily something that we want. Now, it may be up to the physician. And again, I don't think that they actually do it. I don't think that they actually allow it. I think they'll allow pictures. If it was used, though, and the physician was okay with it, we need a chart that it was used. It's not recommended because you never know for sure when they're on or when they're off. Date and times are rarely accurate, and facility doesn't have a copy of it. They can be easily edited and never give a full picture of what actually occurred. Chain of command must be utilized by the RN whenever their personal judgment determines that an intervention is necessary and another practitioner is unable or unwilling to act. We also have the Emergency Medical Treatment and Active Labor Act. It was established to have a safe transfer. I'll tell you, just kind of give you a little small overview. There's a lot that I could tell you about it. It's designed to combat the practice of patient dumping or refusing to treat people because of inability to pay or insufficient insurance, or transferring or discharging emergency patients on the basis of high anticipated diagnosis or treatment cost. So if a pregnant woman comes in active labor, she must, for all practical purposes, be admitted and treated until delivery is completed, unless a transfer under a statute is appropriate. There's a lot of defining characteristics as to how we would need to transfer or why we would need to transfer. But I know that it can be problematic areas of it because of the application and the language involved within that criteria. Excuse me. Now, do all patients in active labor need to be admitted? It's unsure. It's common for patients to present with false labor or in the very early stages of true active labor, and it certainly is not necessary to admit all such patients. So the Emergency Medical Treatment Active Labor Act clearly requires an examination. They have to be medically examined to determine what stage of labor that they're in order to make the determination of whether that patient has reached the level at which they can be safely transferred or if they have to be admitted. So the appropriate legal transfer criteria: receiving facility has to be contacted and agree to accept the transfer and can meet the needs of that patient. The patient is accompanied by copies of their medical record from the transferring facility, and transfer is effected with the use of a qualified personnel or equipment, and that's to include life support. Risk management. Not the last time you're going to hear this right here at all. You're going to hear it throughout your nursing career, and you're going to definitely hear it throughout your nursing student career. It's a process that identifies risk and establishes preventative practices. It develops reporting mechanisms and delineates procedures for managing lawsuits. Effective risk management minimizes the risk of injury to patients and the number of lawsuits against nurses. An example would be the requirement of the Joint Commission to establish an approved list of abbreviations. One that it's kind of near and dear to my heart would be horizontal violence. It happens. There's bullying, nurse-to-nurse bullying that occurs. And it doesn't just affect the nurse, it actually affects the patients. It can affect the patient care. It affects the team unit. It can affect the whole unit, and the patient can be the one that suffers. Sentinel events. It's an unexpected occurrence involving death or serious physical or psychological injury or the risk thereof. It does signal a need for an immediate investigation and response. Reported sentinel events include maternal death related to a birth process, perinatal death not related to congenital condition in an infant with birth weight that's greater than 2,500 grams, and an infant discharged to the wrong family. Failure to rescue. It's used to evaluate the quality and quantity of nursing care by comparing the number of surgical patients who develop common complications who survive versus those who do not. Key components are careful surveillance and identification of complications, acting quickly to initiate appropriate interventions, and activating a team response. I actually sat in on, during my practicum, during my master's program, I sat in on a case that came through that an LPN was going to lose her license for failure to rescue. She did not perform CPR on a patient in a nursing home. She just made an individual nursing decision. And actually the sad thing about it was is part of that nursing decision that she made was within the policies of the facility that she worked at. But the problem is this was not the first patient that that she had encountered that this had happened. I can't remember how many that it actually was, but that is why she was brought before the state board. I felt so bad for her. I really did. My heart broke for her. She sat and sobbed the whole time in there. But you need to follow your policies, you need to follow your procedures, and guys, this is legal ethical, and I mean, this is moral dilemmas that we're talking about. Do you really want to do failure to rescue? Does this patient have a DNR that happens to be on there? Um, I don't know. I was really confused about the policies within that nursing home, and it was somewhere down in South Arkansas. So anyway, when I was talking about that slide, I just thought about that. More ethical issues: maternal fetal conflict occurs when a woman refuses interventions on behalf of the fetus. Um, until fairly recently, the fetus was viewed legally as a non-person. Mother and fetus were viewed as one complex client, the pregnant woman, of which the fetus was an essential part. These interventions infringe on the autonomy of the mother. Attempts have been made to criminalize the behavior of women who fail to follow physicians' advice or who engage in risky behaviors that are considered harmful to the fetus. In 2005, though, Arkansas did pass a bill to include in the definition of neglect the causing of a newborn child to be born with an illegal substance in his or her system, or born with a health problem as a result of a pregnant mother's use before birth of an illegal substance. Some innovations in ethics involved with perinatal nursing: intrauterine fetal surgery, fetoscopy, um, therapeutic insemination, genetic engineering, and stem cell research. I just saw something today as I was preparing to do this lecture. It blew my mind, and it was starting from the very beginning as cells growing embryos into a fetus uh, in an artificial amniotic fluid uh, with an artificial placenta, and it was some. I was just thinking, I mean, how in the world does this seem? It was just crazy. I I I have problems with it, but that's my own personal thing. Other people may not, and that is where we become unique nurses, because we have some who don't mind working with mothers who are undergoing abortion, and that is okay. But you have to delve into your own personal philosophy, your own personal beliefs, your own moral conscience to determine what it seems right for you to be involved in. There's also surgery for infertility, test tube babies, treatment of very low birth weight babies. People sometimes have ethical dilemmas involved with that because we are keeping them alive at viable ages at 21 and 22 weeks. Surrogate motherhood, sex selection, selective reduction of multiple pregnancies, termination of pregnancy following prenatal diagnosis, and cloning. Probably one of my biggest things that bothered me as as a nurse in ICU was I had there was a surrogate mother. She lived in another state. The father of the twins born lived out in Colorado, I think it was, or out in Los Angeles, somewhere out in that area. He had formerly flown a plane for Hugh Hefner, his private plane, but he decided he wanted to have children. He was in his 60s. And so he hired a surrogate who delivered in the state of Arkansas because we have some very lax laws here. Um, okay, that's all fine and good. I understand. I'm not gonna fault you for wanting to have children. What I had problems with though was he had twins, a boy and a girl. I'd come in one day and the little girl had spit up. So I changed out her linens, did all the appropriate things that you would do taking care of these neonates. put pink and purple in there, and they came in and said, "You've got to take all that out. Neutral colors only." What? I mean, we always do pink or blue in ICU. What's the big deal? Well, he was going to raise this young girl, this poor baby girl. I'm sorry if somebody disagrees with me, but for me, it was an ethical, moral dilemma. He wanted to raise her as asexual. He did not want to define her as male or female. Now, we were defining the male as male, but the girl we were not defining as male or female. She was going to be able to decide who she was later on in life. Just a problem. It was just a problem for me. Okay, now we're going to talk about the family and culture. So we're going to talk about the family. What is family? They're a group of individuals. They're related by blood. They're related by marriage, mutual goals. A group of individuals that are bound by strong emotional ties or a sense of belonging, or just a passion for being involved in each other's lives. When we define the family, we defined it by caregiving functions. They are our protectors. They provide us nourishment, and I'm not talking to just about food nourishment. I'm talking about that caring nourishment that take care of every need that we have. Socialization with its members. Some families do isolate themselves from outside the community. I can think of one right now. If you ever watch the Alaskan Bush people, I mean, those folks are way out there. They even kind of have their own dialect, and I don't know if it's real. It's reality TV. It could be something that's put on, but I don't know. They seem kind of real for out there in the bush. But they have their own. They are their own community. They don't seem to be able to function with the world very well. Other families have a wide community network that help them in times of stress. I kind of believe that we as nurses, we're family for the most part. We do protect. We nourish our members. We nourish one another. And we socialize. We know each other's language, do we not? We kind of have our own dialect. So organization and structure within the family. There's the nuclear family. That's the father, mother, and child living together but apart from grandparents. Our extended family that includes grandparents, married siblings, and their families. Reconstituted or blended families. That's a combination of two families with children from both families. Multi-generational. That's any combo of the first, second, or third generation members living within a household. In addition, we have single-parent families. Those can be divorced, never married, or widowed, a parent with at least one child. They are considered the greatest risk because they have lack of support. I grew up in a single-parent family. My mother was in and out of marriages as I grew up, and I can remember that it always felt like that she was scrimping just there was a bill that was going to be put off. We might not pay the electric bill because she wanted to buy groceries. And for the longest time in a period in my life, we went without gas to heat our water up for baths. So every night when I wanted to get a bath, I wasn't able to take a shower. I had to take a bath because I would have to heat up pans and pans of hot water just so I could take a bath and wash my long, long hair. But it was all because it was a choice that had to be made. It was either eat or have warm water that comes straight from the tap. So we chose food over the warm water. So that's why they're kind of at the greatest risk of lack of support. And many times they make just enough money. They're right there on that cusp, but where they can't get help from the state and from government agencies because they make too much money. I had someone that I knew passed away many years ago now, but she had cerebral palsy. Of course, she was single, but she had to be taken care of. She'd gotten to the point where she was no longer able to, she used to get around with crutches, but she was so bent in such a way that she ended up being in a wheelchair. And because her dad, when he passed away, gave her his railroad retirement came to her, it was just enough to support her, pay her bills. And as soon as she started getting that, the food stamps that she was getting were cut down to $40 a month. Now, I find that ridiculous. She couldn't work. She was unable to. She was handicapped, and we're going to give her $40 a month to buy groceries. Okay, just my sidebar of irritation. Cohabitating, this is something we're going to see. Unmarried couples living together. We're seeing more and more alternative or homosexual families that can be with or without children. And then we have adoptive, single parent, a single person, or a couple with an adoptive child. The family systems theory, families are more circular than linear. Everyone has an effect on everyone else. If a child is ill, everyone is affected. If a baby is born, everyone is involved. A new subset is formed when a baby is born. It can be scary for everyone. Moms and dads are created. Grandparents are created. That's the best thing ever. Siblings become aunts and uncles overnight. So applying these principles is a way to guide your assessment and interventions needed for the family. You need to figure out what else going on within a family unit. And let me tell you, you're going to go to postpartum, and it really is not going to be all roses and sunshine. You're going to walk into some rooms, and there is some family dynamics going on there. This part of your assessment, it affects the new mom and it affects the new baby. Okay, so assessment instruments, we might look at a genogram for a family tree. It's a format for drawing a family tree that records information about family members and their relationships over a period of time, greater than probably by about 3 generations. It may go further back. An eco map is a visual representation of a family in relation to the community, and it demonstrates the nature and quality of family relationships. There's a Calgary family assessment model. It's a structural assessment. Internal, you look at who is the family and how are they connected. External, the connection of family members to those outside. And the context is what is the relevant background. With the developmental assessment, you look at stages of young adult leaving home. What happens when they leave home? They usually go to college, marriage maybe next, and they have young kids, adolescents, become empty nesters, and older adults. I already told y'all I refuse to be an empty nester. I'm like on board for that. Task, it's related to the stage of life that the family is in. We want to look at the type of family. Who lives at home? Who is the family nuclear? Is the family nuclear? Is it extended? Are they an other? What is it? What is it about this family? What are their finances? Are they adequate? Is the money divided evenly among family members? When you're walking into a postpartum room, um, if they seem a little stressed about going home, maybe you might delve a little bit further. Is it because they don't have a car seat? Is there something, are they homeless? We need to find out what's going on within that family. Safety, is the home safe? Not just from fire and unintentional injuries. Is this a safe home that we're sending mom and the infant home to? We also have to look at, if we're doing a full-on family assessment and we're happen to go into the room, are there are there smoke alarms present? Do they know the police and fire numbers? Do they know, I mean, I know it sounds crazy, but do they have a cell phone? I mean, we all think that cell phones are available, but if they don't, do they have a way of calling 911 and getting somebody there to help them? Got to look at their health status, their diet, sleep, immunizations, a big one. Emotional support. Do members eat together or spend equal amounts of time with each other daily? Who's the nurturing figure in the family? Who is the primary caregiver to the children? Is a member physically or cognitively challenged? Who's the decision maker or health manager? Who makes the decisions, particularly in the area of lifestyle and leisure time? Who makes sure that the family makes it and keeps the health care appointments? Are we sending mom home and she has no way to take baby to well checks? So family stressors, ethnic and cultural minority status, that's a family stressor. Immigration status, poverty. With poverty, obviously you can tell by the things that I've just said that, I did not grow up wealthy. I did not grow up with money in my pocket. Um, I had to wear clothes until clothes couldn't be worn any longer. I can remember going to school with, pants as high waters. So I understand the poverty level and I understand the family stress that it can cause. It doesn't just go for the single family unit that I was in. It stressed those that were close to me as well. It stressed my grandparents on my dad's side. It stressed my dad, knowing that we were living in such a bad condition. Um, but his hands were kind of tied in what he could actually do because he's had remarried and had a wife. So, you know, that was a stressor there. She's not going to want him helping his ex-wife. Um, Not that he didn't help me or pay child support, but there was a lot of dynamics. So you can see that those are some big family stressors and some big dynamics. Are there challenges with the English language? Do they have fluency? Are they literate? Um, Malnutrition and limited access to housing. Family-centered care. Childbearing is a family event. We've already discussed that. Include family members in all aspects of the care. Childbirth is a normal physiologic process. It's a natural life event rather than an illness. It's generally uncomplicated. It is joyful. Do know, though, as I've said, that it is not all rainbows and sunshine. The goal is to assist expectant parents to make informed decisions, foster family unity while providing safe, quality, and cost-effective care. We want to collaborate with parents, siblings, and extended family members during their entire childbearing process. We want to encourage childbirth prep for parents, include the siblings and any others that might be there for it. We want to make sure that we have involvement of the significant other, whomever that might be, in the birthing process. You're probably going to see some crazy situations out there. You just kind of have to step back, make that part of your assessment, and know that you've got some good nursing diagnoses. The choice of the birthing environment, if possible. I don't know that we have around Little Rock any birthing centers. I think we have more of them up towards the north. Sibling visitation, we want to encourage that. And we want strategies to foster family members' attachment to the newborn. The family in the cultural context. Cultural values and rituals are passed down through generations. There's things that I learned that my mother passed down to me, that her mother passed down to her, and so on. There's things that I know now that I pass down to my children that affects the way that they do things. I can give you this not necessarily a cultural thing, but you know, I I've always told my girls, when you take the babies to the doctors, don't put them down, don't put them down on the floor because they might pick up some virus or bacteria down there. So my daughter had said the other day when she took my grandbaby to the doctor, that she was holding a wiggly baby and, something to that effect on Facebook. And one of her friends said something about, oh, I just put mine down with a diaper on and let her run around. So, there's things that I've taught my girls that they're going to pass on to their children and so on. Power reflects the family's concepts of male or female dominance and cultural practices, social customs, and community norms. Family structure and function are influenced by culturally related health beliefs and values. These factors can affect maternal and child health outcomes. So areas of diversity: race, age, gender, sexual orientation, ability or disability, social and economic status, education, ethnicity, national origin, and religion. Culture, is defined in biological terms based on characteristics such as skin color and hair. Culture is the beliefs, values, attitudes, and practices that are accepted by a population, community, or individual. Ethnicity, social identity that is associated with shared behaviors and patterns. That includes the family structure, their religious affiliation, language, dress, eating habits, health behaviors. You need to avoid stereotyping. For your ethnicity, a group of people who share certain cultural characteristics, such as the Hispanic and Latino, refer to ethnicity, not race. Hispanic and Latino can describe Cuban, Mexican, Puerto Rican, South or Central American, or other Spanish culture or origin. Now, Asian, there can be Asian Indian, Chinese, Filipino, Japanese, Korean, Vietnamese. People with a race ethnicity category can differ greatly in language, religion, dietary preferences, and beliefs about pregnancy. We can't make assumptions about an individual based on race or ethnicity. Excuse me. Acculturation, a process by which people adapt to a new cultural norm, as usually the dominant culture, without foregoing another one. The process for adopting the practice of another group more likely to occur sooner in younger generations, like children going to an American school. It frequently occurs when people leave their country of origin and immigrate to a new country. Living in the U.S., people don't have to give up their customs from their country of origin, but they will probably take on some of the traditions that are inherent in the U.S. Assimilation. Sometimes it's difficult for a group to hold on to their particular cultural beliefs and customs. This occurs as children attend the schools and learn about traditions and customs of the new country. However, no matter how many things change, childbearing is still one that is steeped in traditional beliefs, and we have to respect those. Ethnocentrism, when people think their beliefs and practices are superior to the beliefs and practices of other groups. I think we're seeing a lot of that in our country. It certainly is it's a hard thing to watch happen. It's a belief in the rightness of one's culture's way of doing things. It says my group is best. Childbirth in the U.S. is based on dominant cultural beliefs, primarily Caucasians of European descent. Biomedical model that focuses on curing disease. This occurs when people create their own communities within other communities and practice only those things that they bring with them. Little Italy and Chinatown are examples of people who hold on to old customs right in the middle of the major U.S. cities. Cultural relativism is the opposite of ethnocentrism. It's a concept that a person's beliefs and behaviors should be understood in the context of their culture. You don't have to accept the beliefs of the people, but you must recognize that it's based on a system of logic that is different from their own or your own, and it affirms the uniqueness of each culture. I mean, you might not understand the transgender community. You might not stand for their beliefs. You might not stand for the Muslim beliefs. I'm just throwing different ones out there. It could be religion. It could be a lifestyle. You might not. It may not be your foundation of belief, but when you're taking care of patients, it does not need to come into play. It just doesn't. You have to understand that that patient is unique in their own right, and we have to take care of them and love them and support them. Comprehensive cultural assessment. I'm not going to go through that slide. It is just an assessment. You can read it at your own leisure. Dimensions of culture and decision making. Childbearing decisions may be made by the woman and her partner, the woman's extended family, including several generations, males or male elders, and spiritual leaders. Western European pregnant women and her partner usually make decisions about the health care. There's independence and autonomy. To determine preference, is there someone this is just a question that you can ask. Is there someone with whom you would like to discuss this before you make a final decision? It's just identifying and recognizing that they might not be the full-on decision maker, even if it's just a circumcision. I think that, yeah, I, you can tell there's a hesitance there. So then you might ask, is there somebody else that could help you make this decision? Is there a significant other? Because that significant other might be the one that does make the final ones. Verbal communication patterns, language barriers, dialect, north versus south, the volume of speech, and respect. Always strive to communicate effectively with all patients. It's a challenge for nurses sometimes. Some cultures are taught that saying no to an authority figure, like a nurse or a physician, shows disrespect. And it may not be necessarily a different culture. It could be an older adult. Older adults typically will listen to whatever the nurse or the physician says because obviously our words are gospel. And my husband's grandfather that was that way. Somebody else could tell him that he needed to do such and such, and he would say, no, But if I said, Grandpa, you really need, okay, and he would do so. So you might find some of that as a nurse and in the clinical setting. And I'm not saying within the maternal health, you might find it when you're taking care of GYN patients. Communication characteristics of the dominant culture in the U.S. They have well-developed verbal skills, willingness to disclose personal information, direct eye contact, relative large personal space, and moderate use of gestures. Expressive faces with smiles representing positive or encouragement. But that's dominant in the U.S. That doesn't mean that that's what we're always going to be taking care of within the clinical setting. When working with an interpreter, help the interpreter prepare and understand what needs to be done ahead of time. They're the communication bridge, not the content expert. Be patient. Interpreters' times may not match what others have. Speak slowly and clearly. Avoid jargon and interrupting. Talk directly to the family and not the interpreter. It's easy to look at the interpreter and so even if it's sign language, to look at someone who is going to interpret for you in sign language, and it's easy to look at them and speak directly to them because they're their interpreter, but you don't need to do that. You need to talk to the patient. Health literacy requires the ability to gather and process health information that is provided through written and spoken word. Beyond reading skills requires the ability to communicate needs and concerns to a healthcare professional, understand oral instructions, use number and basic math skills to take meds as prescribed, compute deductibles and copays. That's kind of a big one for us. Nonverbal communication, eye contact, facial expressions, personal space, touch. Some associate eye contact with self-confidence, honesty, and attentiveness. Others consider it invasive, hostile, or a threat to privacy. It could be also considered a sexual invitation. You may see total avoidance or fleeting glances. Facial expressions can also be the opposite of what you expect. Personal space and touch. In general, the closer the personal space tolerated, the more touch is tolerated. Always ask before you do any procedures to make sure that the woman and her family are comfortable. Dimensions of culture and time orientation. Breezing through this slide focusing on the past, trying to preserve traditions or status quo. Focus on the present. Don't make plans or consider the past. Live for the now. Future-oriented, making plans and setting long-term goals. Look at the consequences that occur due to the actions. Modesty and gender. Modesty, exposure of the human body. They may accept public nudity under specific circumstances. In others, women may cover up almost all of their bodies. So physical exams and care during labor can be easily result in culturally inappropriate and unacceptable exposure. Some of them may want to wear a head covering. Gender roles in some cultures, women may be physically abused or permanently shunned if men outside of the immediate family touch them. So we have to, must assess personal preferences and cultural, any prohibitions. You know, there is a cultural uh, dimension about causes of illness, the evil eye. Diseases or accidents or other misfortunes are passed by a malicious look or a glance. Individuals might wear amulets to protect themselves from that evil eye. Breach of taboo. Disease befalls the individuals who do something that is forbidden. Causes of illness and body imbalance. Illness occurs when the balance within the body, yin and yang, or between hot and cold qualities, is disturbed. Health is a state of balance among body fluids. To avoid imbalance, people avoid extremes. Yin represents female, cold and darkness. Yang represents male, hot and light. Um, Cold foods, fruits and vegetables, milk products, foods sour to taste, and hot foods such as animal products, chili, spices, and ginger and iron supplements. Um, so the illnesses may be treated with substances that have the opposite property of the illness. Pregnancy is considered a hot state. So what are they going to do? They're going to have cold foods. So if postpartum is considered a cold state, they're going to want hot foods. They're going to have those spicy dishes that mom's going to bring in for them. Cultural health beliefs, ideas about conception, pregnancy, and childbearing practices are passed down from generation to generation. Many societies do not consider pregnancy an illness. They may not seek advice from a healthcare professional or even get prenatal care. They may seek and follow advice from elders and family members, though. Here's some perinatal cultural practices. I'm not going to read this slide. This is something that you can look at and be aware of. Cultural health beliefs determine if cultural practices are supportive, neutral, or harmful. If supported or neutral, incorporate into the plan of care. If harmful, discuss with that client. Find out what it is that you need to understand for their reason for refusal. Identify any ways that you can. I don't like to use this word persuade. I would like to use the word encourage expectant mother to accept any interventions. Um, Accept the expectant mother's decision to refuse, though, the intervention if she's not willing to adapt to her belief system. Explain alternative therapies that might be acceptable to the expectant mother within her cultural belief. Preconception care. There's issues across cultures. Ideal age for women to first become a mother, preferred number of offspring, preferred interval between pregnancies, appropriateness of preconception testing for genetics. I mean, we all have that pre-notion of what we're going to do. I mean, we grow up in this culture, and some of us may be like the Duggars, and we grew up in a culture where it's acceptable for, to have 18 kids, 19 kids and counting, however much it is. And so, we've got two of the girls now that are married, and both of them have a child, and one of them got pregnant very soon after having the first one. So you can see that that's a culture in itself. I'm not judging the Duggars by no means. I'm just showing you that is a culture that it is acceptable and expected that they're probably going to end up having multiple children over their lifespan, and they're probably going to have 19 kids and counting. Reasons women do not value or attend prenatal care. Maybe they have difficulty accepting the pregnancy, depression, discomfort with specifics of prenatal care such as waiting times and payment requirements. It's expensive to seek prenatal care. You might have insurance that covers a portion of it, and then you're going to receive a bill from the physician that says this has to be paid. Uh, if a woman or her support persons leave any prenatal visit feeling disrespected, unwelcome, or marginalized, they may avoid future visits or disregard the information they receive. Prenatal testing, the nurse's role is to facilitate informed choices by the woman and her family. Some genetic conditions are associated with certain races or ethnicities. To avoid being insensitive, some diseases are common in specific populations, ethnic and racial groups. Are you aware of anyone in your family that has a disease? This is just something that we can ask. You don't want to say you're from you're Asian American, and we know that that's just not how you want to start that out. We just know that some diseases are very specific, and we want to look at your ethnicity and determine if there's anyone in your family that has suffered from any diseases that you need to tell us about, so we know how to take care of you prenatally. There is a comprehensive perinatal cultural assessment. Um, how does your family or community feel about your pregnancy? What does being pregnant and having a baby mean to you? Are there certain activities you should avoid while you're pregnant? Is it okay to have sex during pregnancy? We might tell them it's okay to be sexually active, but we need to know what kind of culture that they are from, because it may be unacceptable through there. There's a prenatal nutritional cultural assessment. You're looking at foods. You're looking at nutritional counseling. What types of foods do they have, or do they practice religious practice such as fasting on a daily or a weekly basis? Just some things that we have to think about. Intrapartum care, the birthing environment. Atmosphere and policies of biotechnological technological birthing units may present some cultural challenges for women. They may be anxious and fearful as they are forced to conform to medical center policies and procedures. I know people like this, and they were very apprehensive about going into labor and delivery. Some of them had birthed at home in another state, and when they came here, they had to end up going to the hospital to birth, and it was they felt that their culture was, they weren't going to be able to follow their cultural beliefs in there, and so it was, we have to be aware of this. We have to be sensitive. Support persons during labor and delivery. Expectations about who accompanies or supports a laboring woman vary across cultures. Maybe the male doesn't come in for the birthing process. The nurse's role, we have to be familiar with those cultural traditions, specific preferences of each woman. I'm not going to read this cultural care, intrapartum care cultural assessment. These are typical questions that we're going to ask, and I'm going to move past that and get on. Cultural responses to pain. Perceptions of childbirth, pain, behaviors, and management are culturally bound. How should you behave during labor and birth? Is it okay for you to cry, be quiet, moan, express discomfort? Some women may prefer to be active during labor. Some may prefer to use herbs, acupressure, massage, meditation, hydrotherapy, birthing balls, and position changes to reduce pain. Some prefer to squat to give birth. And so we have to find out, are the herbs and herbal teas customary during labor for their culture? Restoring the balance to the body. Concept of postpartum vulnerability is based on beliefs related to imbalance or pollution. Imbalance is disharmony caused by the processes of pregnancy and birth. The pollution caused by the unclean bleeding associated with birth and postpartum period. Restitution of physical balance and purification occur through dietary restriction, ritual baths, ceremonial events, seclusion, and restriction of activity. Again, I'm going to skip through these questions. You can read these questions. Postpartum care for postpartum depression occurs in most cultures throughout the world with similar levels of prevalence at about 10 to 15%. So not one culture is exempt from it. Culturally specific risk factors for postpartum depression, placing a higher value on having a male rather than a female child. Immigrant or refugee status, inability to practice postpartum cultural rituals, or lack of effective social support network. Newborn care, also influenced by culture. Feeding. Some cultures consider colostrum essential to establishing nutrition and maternal-infant bonding. That's ours. Others think colostrum is dirty, old, or unfit for a newborn. Names. As a hospital stay becomes shorter, members of many cultures find it challenging to follow hospital naming conventions. What's your baby's name? It's one of the first things that we ask. Did you have a boy or a girl? Oh, what's his name? Fetal and neonatal death, we have to assess the meaning and loss and grief. So what are some important cultural traditions and rituals for coping with the dying and handling of the deceased body, and also honoring the deceased loved one? What does the family believe happens after death? And what are their expected expressions of grief and acceptance of the loss? What family roles exist in the coping with the death? The Hispanic Americans, food practices, that hot and cold theory I talked about, that's what they're going to adhere to for the foods. They may avoid milk during pregnancy. Postpartum, they may have boiled milk and toasted tortillas for 2 days. Communication-wise, you might have some nonverbal. Direct eye contact may be avoided also. Prenatal care, pregnancy considered a normal state, but they may delay care. May use folk medicine. Meds include iron and vitamins may be seen as potentially dangerous and avoided. Their labor, pain, crying out or shouting is acceptable. Walking is recommended to encourage a quick birth. They have fear of unnecessary or dangerous medical interventions such as a C-section, separation from family members, and loss of privacy. Prefer the use of patera or midwife, and they're strongly influenced by their mother-in-law and mother. During the postpartum period, they're going to have bed rest for 3 days. They're going to avoid bathing for 14 days, avoid exposure to cold air, and they're going to bring their legs together after birth. So you may have some difficulty with assessment. Newborn, breastfeeding is usually delayed 3 days due to the belief that colostrum is dirty and spoiled. The male infant may not be circumcised, and the belly band may be used to prevent umbilical hernias. The African American culture, in the prenatal care, pregnancy is a state of well-being, and they may delay care. Taking pictures during pregnancy may cause stillbirth. Reaching up during pregnancy may cause the umbilical cord to strangle the baby, and they may use self-treatment for discomfort. During the labor, response to pain may be stoic or cry out. They might have emotional support from mother and other women. I had a student that graduated that was pregnant, and we laughed during clinical talking about. She said my mama and my grandmother are crazy. Those are her words. She was talking about some of their beliefs about her during the prenatal period about not reaching up. She's going to put cords or put knots in the cord, and then we'll talk about postpartum. But one thing that's not mentioned in the postpartum part of this is that her family had the belief that when she delivered and it was around a holiday, everybody was coming to her house for Thanksgiving and Christmas because her grandma for sure couldn't understand her leaving the house before 6 weeks and taking that baby out. And she was like, Grandma, I have to finish school. I'm going to school. Um, and so she said it was just a source of really a lot of stress within her family because she didn't want to follow a lot of those cultural beliefs that her mom and her grandmother were trying to pass on to her. During the postpartum period, they may prohibit tub baths and shampooing of hair. They have a strong feeling of family, community, and religion. The newborn, they may view breastfeeding as embarrassing, consider the infant who eats well as good, may introduce solid foods early, may oil the baby's skin, and may use a belly band to prevent umbilical hernias. The Asian American culture, communication, they're going to nod politely, does not mean that they're understanding you. And sometimes we take that, when they're nodding at us, we take that as they are understanding completely what I'm saying. Asking questions is seen as disrespectful. Silence may mean respect. Nonverbal eye contact, again, may be avoided with this group, with authority figures as seen as a sign of respect. They're going to keep a respectful distance. Dietary preferences, pregnancy considered cold, so they're going to avoid cold foods. They may also omit milk from their diet because it causes GI distress. During the labor process, the father does not play an active role. Female family members are present. Pain, they're going to have a very stoic response, and you have to assess nonverbal cues. During the postpartum, activity restriction for 30 days. Warm room, shower, and bath prohibited. The newborn, the father is the head of the household, so the woman is a subordinate. The birth of a boy is the most preferred. And delay breastfeeding due to the belief that colostrum is dirty and harmful. The Native American communication, don't interrupt the speaker. Long pauses are part of the conversation. Don't interrupt the speaker. Long pauses are part of their conversation. Loudness is associated with aggression. Nonverbal, their respect communicated by avoiding eye contact and to keep a respectful distance. During prenatal care, pregnancy is considered normal, so they may delay care. Labor, pain, they're going to be stoic because that's highly encouraged. They're generally undertreated for pain. Female relatives may be present. The father may be expected to practice certain rituals and be absent following the birth. They may also use herbs to promote contractions and stop bleeding or increase breast milk. During the postpartum period, the remnant of the umbilical cord may have spiritual value. The family may request it. They may bury the placenta. Newborns may delay breastfeeding due to the belief that colostrum is stale or dirty. You use cradle boards to carry the baby and don't handle the baby often. The Arab American communications, head nodding and smiles don't always mean that they're comprehending. They may speak English but not admit it. May downplay or ignore symptoms because illness can be shameful. They may have a flat affect, not comfortable with between gender touching, may avoid eye contact with men. Their pain, they may be very expressive. Pain is feared and may cause panic. If there's a genetic defect, God's will, they may refuse genetic counseling, so not to defy God's will in their life. During the prenatal period, they believe pregnancy is not an illness and prenatal care unnecessary. Little or no prep for birth of our baby. They're very present-oriented. Labor, they tend to be passive, tense muscles, and wait for delivery. Father not expected to participate. A C-section may be greatly feared by them. During the postpartum period, they expect to have complete bed rest. They may fear bathing or showering. And breastfeeding, they may believe that colostrum is harmful to the baby, so they also may not request assistance for fear of imposing on staff. The East American Indian, communication loudness may be interpreted as disrespect. Uh, Touching, not common. Direct eye contact may be considered a sign of rudeness or disrespect. Silence usually indicates acceptance. Prenatal care of the pregnancy is considered a hot state, and cool food is encouraged. Labor, they may be passive, may moan, grunt, or scream. Female family member probably be present. Father may not be present at delivery. May not accept payments. After birth, allow Muslim father or grandfather to recite prayers in each ear of the baby. After birth of the baby, the sex of the child may not be told to the mother until the placenta is delivered. During the postpartum period, the mother may want to keep warm and they may not want to shower. So when we're developing cultural competency, it's critical that we examine our own cultural beliefs. We identify our personal biases, attitudes, stereotypes, and prejudices. Make a conscious decision to respect values and beliefs of others. Use sensitive, current language with describing the client's culture. Learn rituals, customs, practices. If you don't know them, please by all means go and look it up. Don't just assume this is what we're doing. Find out if that's a cultural belief, and then you can gear your assessment towards that cultural assessment towards asking those strategic questions that are designed just for that culture. Also called being culturally competent is also called multiculturalism, culturally sensitive, intercultural effectiveness. It involves acknowledging, respecting, and appreciating ethnic, cultural, and linguistic diversity. Provide services for an interpreter if a language barrier exists. Learn the language or key phrases of at least one culture group with whom one frequently interacts. What is the biggest culture group that we have coming into the healthcare system in the U.S.? I think it's probably the Hispanic community. That culture has been on the rise for a while now, and so we all don't know the Spanish language, and but if we could learn some key words, we could communicate with them more effectively. The nurse's role, we want to respect our patient's wishes. We want to involve her in decisions. We want to provide privacy. And we have to use culturally appropriate learning aids for them. Integrating cultural competence with care plans. We have to recognize cultural importance of the family. Family supports the patient, guides decision making, and preserves the cultural integrity in healthcare interactions. Families are an integral part of the patient's healthcare plans. If you don't recognize the family as part of the planning process, then you're not going to receive their cooperation, and your plans are going to be for nothing. Nursing diagnoses. These are just some common nursing diagnoses. I'm not going to read those to you. Crash. Crash is something important for you to know. Crash is the course in cultural competence. C is for culture. R, show respect. A, assess and affirm. S is to show sensitivity and self-awareness. And H, do it all with humanity. That is to the end of my presentation. I hope that you have found it useful and enjoyed it. I will see you in the classroom. Thank you.